these talks are, I guess, an acknowledgement that GPs have a very important role in detection of lung cancer, but also that, in your experience, you probably won't see many lung cancers per year. You may only see one or two, when you see a variety of presentations to your general practice, sometimes it can be very difficult in fishing out what is lung cancer and what are other pathologies. So hopefully by the end of the night, it will be a good refresher about lung cancer and how to detect lung cancer, but also some of the processes that we have from a tertiary centre about working up people with lung cancer. I'd also like to talk about a little bit about lung cancer screening, and obviously if there's any questions along the way, I'm more than happy to answer questions along the way. So just a little bit of an introduction. Lung cancer is the fifth most common cancer diagnosed in Australia. However, it is the leading cause of cancer death. The 5-year survival rate has budged a little bit, but not dramatically. Usually it's been quite about 12 to 16%, but as of recently, through some of the statistics in Australia, it's been quoted as 16%. In 2017, there'll be an estimated 12,000 new cases of lung cancer, a slight majority being male. Thank you. So this is a graph just giving you an outline of cancer death, and as you can see in the male graph, smoking rates continue to rise, and that was a reflection of cancer death. But as you can see from 80s onwards, it started to tapering off, and that's got to do with a reduction in smoking rates amongst males. In terms of females, you can see from the 1940s to the 1970s, the rates were pretty low, and that's probably related to behaviour and smoking. However, the rates rose from 1970s and continue to rise, unfortunately, and that's reflective in the number of cancer presentations, or lung cancer presentations in females. In terms of incidence by age, the older you get, as with majority of cancers, the more likely or the higher the risk of cancer, and that's also reflective in lung cancer. I like to point out that there are some lung cancers that, sorry, we're just having some difficulty. Yep, okay. Sorry about that, just some IT issues with the PowerPoint slides. I just want to mention that there is a small percentage of patients that are young, and that they shouldn't be forgotten. And I'll talk a little bit about that in a couple of slides' time. In terms of risk factors, smoking is the biggest risk factor in lung cancer. 90% of males and 65% of lung cancer presentations can be contributed to lung cancer. Sorry, there's some missing. That bowel cancer, don't worry about that, and the lifestyle factors. In terms of environmental factors, passive smoking can contribute to your risk of smoking. Up to 10-20%. Occupational exposure, as we know in Western Australia, asbestos exposure does increase the risk of lung cancer. There are other chemicals that do expose you to increase the risk of lung cancer. In terms of air pollution, Australia is actually not too bad in terms of air pollution, and it's probably not a huge contributor to lung cancer in Australia. As I mentioned before, in terms of other factors, age is, as you increase your age, you're at higher risk of any cancer, including lung cancer. In terms of family history of lung cancer, unlike other cancers where there's, say, in breast cancer, where there's BRCA mutations, although family history does contribute to your risk of lung cancer, I think that's mainly in combination, it makes you more genetically susceptible to cancers, but in combination with other factors such as smoking. Certainly previous lung diseases such as COPD, interstitial lung disease increases your risk of lung cancer. Now, this is very important in terms of the discussion today about early detection of lung cancer. As you can see here, the earlier the stage of lung cancer, the better your 5-year survival rates. Now, unfortunately, these survival rates aren't as comparable to some of the other cancers. For instance, in breast cancer, in the early stage or stage 1 breast cancers, 5-year survival rates are really close to 100%. But you can see here in terms of the stage 1A and stage 1B, the 5-year survival rates are just touching under 50%. And that's just to remind you about stages. And I didn't want to go into too much detail about the stages, but stage 1A, 1B is a localized lung cancer that's not spread to the nodes. We go down to 2A and 2B, and that is determined by the T stage in terms of the size of the cancer, but also the nodal status of the lung cancer. And you can see the survival rates slightly go down to the 31% or 30%. From stage 1A to 2B, the standard treatment is surgery or resection of the lung cancer. In the later stages, we may offer adjuvant chemotherapy as part of treatment of lung cancer. Then we go down to stage 3A and 3B, which again is a more extensive size of lung cancer and nodal disease. And you can see the 5-year survival rates dramatically drop to 40% and 3B 5%. The treatment, generally speaking, would be a combination of chemotherapy and radiotherapy. On the other occasion, in some 3A lung cancers, we are able to downstage them to a lower stage for resection. Unfortunately, stage 4 lung cancer, and again, this emphasises the need to detect lung cancer early, is terrible at 1%. Yes, we do have new treatments for lung cancer that may budge the statistics very slightly, but again, it's a very poor statistic to have stage 4 lung cancer, and hence why it is important to detect lung cancer early. Just to remind yourselves about the pathology of lung cancer, and traditionally we divide into non-small cell lung cancer and small cell lung cancer. And the reason for that tradition is historically due to the treatment for these lung cancers in terms of chemotherapy. So non-small cell lung cancer had a particular protocol for chemotherapy, and small cell had a different treatment regimen. However, we're getting to the age of molecular subtypes, and that means there are different types of treatments out there. So for instance, adenocarcinoma, there are some mutation drivers that are such as EGFR and ALK. And if you're found to have these mutations, there are different treatments that are not chemotherapy based that you can offer. And they tend to be, one, offer patients better prognosis, and two, tend to be less toxic than some of the chemotherapy agents that we have. Now, as I said before in the outset about age and lung cancer, commonly these mutations are found in younger patients and commonly in non-smokers. So it is important to think about lung cancer in non-smokers and in young patients. Other subtypes of non-small cell lung cancer includes squamous cell carcinoma and large cell carcinoma. And then there's small cell lung cancer, which unfortunately 5-year survival rates for small cell lung cancer are less so than small cell lung cancer. So the early stage small cell lung cancers, the 5-year survival rate is around about 30%. And with the metastatic disease, again, very low percentage in the 1 to 2% of 5-year survival rates for stage 4 or extensive small cell lung cancer. So in terms of the signs and symptoms, and this is again as a refresher of symptoms of lung cancer: hemoptysis, dyspnea, thrombocytosis, weight loss or fatigue, loss of appetite, unexplained bone or chest pain or shoulder pain. That's related to metastatic disease to the bone, cough, persistent hoarseness, non-resolving pneumonia, and neurological signs that may be suggestive of, again, metastatic disease to either the brain or to the spinal cord. Now, when you look at that list of symptoms, now the problem for, I guess, general practitioners is that these are very common symptoms that you will have in your practice. And as I said from the outset, detecting lung cancer can be tricky when you have a lot of patients that present, say, with cough or shortness of breath or fatigue. Again, they're very common non-specific symptoms that are very common in general practice. So what we have here is, and this is from the CAPER study in terms of, and for those, who don't know what CAPER stands for, it comes from a study in the UK, so Cancer Prediction in Exeter, which is a place in the UK where the study was undertaken. And they looked at symptoms and how and looking at positive predictive value as a predictor for lung cancer. And I don't know if many of you will be dialing into the other webinars, but unlike some of the other cancers, a lot of the positive predictive value is less than 2, and that again is probably an appreciation of how hard it is for general practitioners to detect lung cancer, because these are very common non-specific symptoms that you might have in your general practice. Probably the key thing, and I know this is a graph for non-smokers, and I'll be showing the smoking slide later on, but some of the key aspects are hemoptysis, and you can see there in red, which it shows a high probability of cancer, and in this graph it's greater than 5%. So hemoptysis is a big red flag for lung cancer, but unfortunately, hemoptysis is not a very common presentation to the community or to general practice. So I guess from your perspective, if you had a patient who presented with hemoptysis, either as a single clinical feature, which as you can see is a positive predictive value of 2.4%, or in association with other symptoms, that's a red flag for thinking about lung cancer as a differential diagnosis. Thrombosis has been known traditionally to be a negative predictive value for prognosis of lung cancer, and certainly, again, in terms of what they found in this UK study, a high positive predictive value for lung cancer. And you can see here, in association with loss of weight, 6.1, which is again a large red flag for considering lung cancer as a differential diagnosis. But you can see on the flip side, on this less than 1% probability of cancer, is cough, fatigue, shortness of breath, and chest pain. That's an acknowledgement, as I said before, that this is very common presentations. As I mentioned before, smoking is a huge risk factor for lung cancer, and the PPVs for these symptoms changes substantially with smoking. And as you can see, there's a lot more red and orange in these graphs, reflective of how smoking is a huge risk factor for lung cancer. And certainly, I think, compared to the other slide, there's a lot of things that are greater than 10% positive predictive value. These squares here, they were unable to give a PPV for these associations. However, it is reflective that a combination of, say, hemoptysis and loss of weight is still a important red flag for lung cancer. Just a reminder of positive predictive value, that it's patients with disease over the patients with symptoms. So the more likelihood or the probability of cancer for a given symptom. Now, this is a really great graph that I found from Cancer Australia 2012, and it's reflective of what we've talked about, but gives you a guide of what you should be doing in terms of investigations from a general practitioner point of view. So as I said from a couple of slides ago, and this top table shows the signs and symptoms that I've discussed before. Hemoptysis, as I mentioned, is a big red flag for lung cancer. But again, these are some symptoms that I've already talked about. One of the things that they've mentioned, which is a bit more elaborate to the other slides, is that if you have unexplained persistent symptoms with signs lasting more than 3 weeks, or less than 3 weeks in patients with known risk factors, such as smoking, then you should be thinking about lung cancer. And again, here are some of the symptoms that I've already showed you in some of the slides before. I think one of the key things about this slide is lasting more than 3 weeks. And as I mentioned before, it can be difficult when someone comes in with shortness of breath or cough in your practice in a short limited time to think about lung cancer, because again, it won't be a common presentation in your practice. So I guess as a safety net, you should be thinking about having a backup plan in terms of checking up on the patient in a couple of weeks' time, either asking the patient to either represent or contact your practice if symptoms are persistent despite treatment for whatever your initial diagnosis is, or asking them to come back to your practice in a couple of weeks' time. There are some other big things that you should be thinking about: persistent hemoptysis, or signs of the superior vena cava, and that is including facial edema or stridor. And again, here, massive hemoptysis and stridor should initiate immediate referral to the emergency department. So going back to common presentations to general practitioners in this part of the table, if you're suspicious of lung cancer, then a chest X-ray is the initial first step. Going to the left side, if the chest X-ray is normal, then it's not unreasonable to continue on with a surveillance approach. But as I mentioned before, you should be monitoring for persistent symptoms. So again, it is worthwhile reassuring your patient if the X-ray is normal, but also advising them that if any persistent symptoms, to contact you. If you're worried about someone who, and this is again a very common presentation in general practitioners, and again, a common story when I have a patient with lung cancer, they may come with a chest infection, pneumonia, and with that, the X-ray shows consolidation. And as you would rightly do, you would treat them accordingly, and commonly with consolidation and pneumonia, you would give them antibiotics. But it is definitely worthwhile to repeat the chest X-ray in 6 weeks' time. And if there is persistent changes in the X-ray, then you should investigate that with a CT scan. Quite commonly, pulmonary nodules are visible on X-rays and CT scans, and that can confuse the picture in terms of what is benign and what is malignant. If the patient has had an X-ray previously, it is worthwhile going back to them, back to the previous X-rays. And if the X-rays are stable, then it's worthwhile just to continue monitoring the patient. And again, if symptoms are persistent, then you should think about doing a CT scan. However, if the X-rays do show a change from previous imaging, then pursuing that with CT scan is very warranted. If you've got some red flags, but the X-ray is normal, then it may be worthwhile doing an urgent referral to a tertiary centre and organising a CT test at the same time. So those red flags that I talked about, hemoptysis, or two associated symptoms such as loss of weight and shortness of breath, or loss of weight and cough, would warrant a specialist referral to a lung physician and a concurrent chest CT scan. Or the obvious, if the X-ray suggests lung cancer, then an urgent referral to a lung cancer or a physician in a tertiary centre would be warranted. Now, the good thing about Fiona Stanley Hospital and St Charles Gairdner Hospital is that they do have a fast-track lung cancer service that facilitates further investigations and treatment at an MDT level, and I'll be discussing that at the next slide. So if you do decide to go to pursuing a CT scan, then again, these pathways show you what to do next, and they are pretty obvious. If the CT scan is normal, again, your safety net, monitor for persistent symptoms, and if you're concerned about your symptoms or they're not changing, then again, referring to a lung physician is very reasonable. Again, if you've got abnormal findings, and they may or may not be lung cancer, or you're not sure, and again, some radiologists may hedge their bets about whether it's lung cancer or not when they report a lung nodule, then again, referring to a respiratory physician if you're not sure is very reasonable. As I mentioned before, pulmonary nodules are very common when you do a CT scan, and there is a lot of difficulty in deciding whether they're benign or malignant. Again, reviewing previous CT scans, and quite commonly radiologists will review previous CT scans, but part of the problem with having multiple radiology services in Western Australia is that you may have different CT scans from different places, publicly, privately, and it is worthwhile having a look at the CT scans yourself and just looking at the nodules and just seeing if there is an increase in size of those nodules. Now again, if there's no change, then it's worthwhile doing a surveillance approach, and that can be either through yourself or through a respiratory physician. However, if there is a change in the nodule, say an increase in size, then an urgent referral to a lung specialist is very reasonable. So in terms of what we do when they do come to a tertiary centre, as with all doctors, we do a clinical history examination. If not done so already, we do a chest CT of IV contrast. If there is a suspicion of lung cancer, then we'll proceed through to a biopsy. And this can be done through various means, either through CT guided biopsy, ultrasound guided biopsy, if amenable through ultrasound, or through endoscopic bronchial ultrasound through the respiratory unit. If there is metastatic disease, then obviously that would be easier to biopsy. So if, say, for instance, there's a supraclavicular lymph node, or a bone lesion or a liver lesion, that would be easier to biopsy, then we would pursue that. PET scans are done if patients are considered for curative surgery. So PET scans do detect metastatic disease better than chest CT scans, and this I guess in some ways saves patients from potential surgery if unfortunately they are found to have metastatic disease. We will arrange pulmonary function tests if patients are considered for surgery, and obviously if they have a good FEV1 and DLCO or corrected gas transfer, then they may be suited for surgery. As I mentioned before, endoscopic bronchial ultrasounds is a new technique that multiple hospitals have access to in terms of sampling some of the mediastinal lymph nodes, which are not amenable to normal CT guided biopsies. And majority of lung cancers are discussed at an MDT level, where there are both respiratory physicians, medical oncologists, radiation oncologists, cardiothoracic surgeons, cancer network nurses that are involved in the decision making of a patient. It also allows fast tracking to the appropriate treatment. So it is very important to, if you are concerned about a patient with lung cancer, to refer them to the appropriate lung cancer service. Now, unfortunately, unlike other cancers such as breast cancer or colorectal cancer, we do not have a lung cancer screening program in Australia. There is evidence for lung cancer screening, and this is a study that was published in the New England Journal of 2011. It was a national lung surveillance trial, and this was done in the United States across 33 sites, and roughly about 50,000 patients randomised to either low-dose CT scan or chest X-ray. And in terms of the imaging, 3 annual surveillance screening tests were done. Now, the really key issue, and this is the thing about the lung cancer screening, is that there was a 20% relative reduction in lung cancer of CT versus chest X-ray in screening. These were patients that were at risk of lung cancer in terms of their smoking history. So 30-pack year smoking history were eligible for the trial. Patients who were ex-smokers up to 15 years were on the trial. And the age group was from 55 to 74 years old. Excluded were patients who had previous cancer. And the compliance to the study was very high at around about 95%. So the figures are statistically relevant. And in terms of the rates of positive screening tests, in terms of low-dose CT scan versus chest X-ray, 24.2% versus 6.9%. Now, in terms of the cons of this study, they picked up a lot of false positives. So as I mentioned before in a couple of previous slides, you do detect a lot of lung nodules, and a lot of these lung nodules that were suspicious for lung cancer were biopsied, either through CT-guided biopsy, and a vast majority of them turned out to be benign. And obviously exposing someone to the risk of biopsies, especially with CT-guided biopsies of a lung nodule, exposes patients to pneumothorax, bleeding and infection. Although I will say that the risk of those things are relatively small, but unfortunately there is a risk involved with that. So this is a publication or an editorial from the MGA a couple of years ago from two of our prominent lung physicians in Western Australia, Annette McWilliams and Fraser Brims. It's more of a discussion about lung cancer screening, and there is a large percent of patients or people that would be eligible for lung screening. As I mentioned before, it is so important to detect lung cancer early because of the survival benefit if you detect lung cancer early and they proceed to surgery. In terms of the cost-effective ratio, it is very similar to some of the lung cancers, and the quality is roughly estimated about 10,000 Australian dollars. And that's reflected the fact that if someone presents with metastatic disease, then treatments are expensive. As I mentioned before, there are lots of new lung cancer treatments, including immunotherapy, which has received a lot of media, and they can be very expensive, either to the government or to the individual if they have to self-fund. And that could, the cost sometimes for immunotherapy can range from about $3,000 to $5,000 per treatment, and that could end up being possibly even up to $100,000 per year per patient. So as you can imagine, treatment for metastatic disease is expensive, and it would be very worthwhile to have lung cancer screening. However, there are some uncertainties in terms of recruitment strategies. What is the best recruitment strategy? Unlike other screening strategies such as breast cancer, where all patients at a particular age group are offered mammograms, in lung cancer, the screening tool is probably more beneficial in lung cancer patients. But do we do that in other risk categories, such as have they got other disease process such as COPD? Smoking cessation is extremely important in reducing lung cancer and other lung-related problems. And certainly intervention or integration of smoking cessations is important if we are to do a lung cancer screening program. As you are aware, smoking increases your risk of lung cancer by 10-fold compared to non-smokers. As reflected with the other study done by the US, the management of pulmonary nodules is a challenge, and there is a high percent of patients that will have benign pulmonary nodules, and that makes it very tricky in terms of deciding when should someone be biopsied, not knowing that there is a high false positive. And again, the most cost-effective strategy involved in terms of low-dose CT scans and proceeding to biopsy. So I've got 2 case studies just to summarise what we've talked about. I have a 65-year-old gentleman who presents with a 2-month history of dry persistent cough and a 5-kilogram unintentional weight loss, has a past medical history of COPD and has an extensive smoking history that was but previously ceased 5 years ago. As you can note, there are some red flags, persistent cough, weight loss and COPD, but again, some of these symptoms can be non-specific and can be related to, say, other pathologies. This patient does have COPD, but if you use the CAPEL tool or the graph that we've talked about, the PPV is 2.3%. So a chest X-ray would be very reasonable given some of the symptoms that this patient had, and this chest X-ray did show right upper lobe mass as reflective in the arrow there. This patient proceeded to a CT body, and fortunately this patient had localised disease with no lymphadenopathy or no metastases, and was promptly referred to a tertiary hospital, discussed at MDT and proceeded to surgery. Case study 2, I've put this intentionally to remind you that there will be a group of patients that are non-smokers, that are young, that you may need to consider lung cancer as a differential cancer. I've put their Asian because a lot of young Asian females who are non-smokers commonly have a mutation driver. So this case study is a 40-year-old Asian woman, again with weight loss and dyspnea, who is a non-smoker. And by, again, the previous graph, PPV of 2%, chest X-ray showed multiple lung lesions. Unfortunately, this patient proceeded to a CT scan that showed multiple lung lesions, as you can see from that slice that I've put up. This patient was promptly sent to the Fast Track Lung Clinic at Fiona Stanley Hospital, and a biopsy confirmed an EGFR positive lung adenocarcinoma, referred to myself, and was commenced on a EGFR inhibitor and responded very well to treatment. And just to remind yourself that not all cancer treatments for metastatic disease are chemotherapy. There are target therapies and immunotherapy, so it is important to have a discussion with patients about treatment options, certainly if they are found to have a mutation driver. So in summary, lung cancer is the leading cause of cancer death. Survival rates are poor, especially in metastatic disease and comparatively to other cancers. However, as I've pointed out, early diagnosis improves outcomes, and we do have strategies in place to expedite investigations treatment if appropriately referred early. I'd like to thank you for your time, and if there's any questions, I'll answer them.
Okay, so if anyone has any questions, they can write it in the chat bar and we'll get them answered. So there's one question that's come in that says, can you explain again a bit about the PET scan and what it is exactly an indication?
Yep, sure. So PET scans, I guess this is a layman term that I use when I talk to my patients. So PET scans pick up activity, unlike CT scan that looks at size. So anything that was metabolically active is picked up by PET scans. And so, as I mentioned before, PET scans are a bit more sensitive, and more specific for metastatic disease, and compared to CT scans. Now, there are some caveats to that. Small lung nodules, say less than 6 millimeters, are not picked up by PET scans, so you can get false results. And other things can be detected by PET scans. So inflammatory nodules, infection can be picked up by PET scan. That can sometimes blur the picture. But in terms, I guess, of access to PET scans, they tend to be done at a tertiary centre, and usually are for patients who on CT scan are shown to have only a single nodule or locally advanced lung cancer. It is not worthwhile pursuing a PET scan in metastatic lung cancer because that already shows that it's metastatic lung cancer, and PET scans don't add value in terms of detecting other diseases elsewhere, because the treatment protocols are much the same in metastatic disease, whether you detect it through CT scan or PET scan. So my advice to general practitioners would be to arrange checks around CT scans, then refer to a tertiary centre for a PET scan, so that facilitates the appropriate discussions through the relevant specialists.
Okay, there's one question that's come in that says, should initial CT always be with contrast?
Ideally, yes, and for the reason being that for radiologists, it is sometimes difficult to assess lymph nodes, and so having IV contrast helps differentiate where the lymph nodes, if they're pathological. So ideally, they should be with contrast. I acknowledge that there are times where there is a contraindication to IV contrast, say they have renal failure or a reaction to iodine, but ideally, yes, patients who are suspicious of lung cancer should have CT scans with IV contrast for the reason that you can detect lymphadenopathy better with CT scans with IV contrast.
Another question asked, how useful is NSE?
Not useful. So tumour markers aren't great for diagnosis of lung cancer. In my opinion, lung cancer should be diagnosed through imaging and biopsy. Biopsy is always key for a medical oncologist in deciding what treatment we should be giving a patient. And tumour markers, in my opinion, don't have a great role in lung cancer. So, and hence why it's not reflective on the treatment, it's the investigation algorithm that I showed you from Cancer Australia. It really relies on signs and symptoms, chest X-ray and CT scan.
Another question asked, when should HRCT be used?
Yeah. So HRCT, and again, I'm not a respiratory physician, but probably not necessary in lung cancer. It is more helpful in interstitial lung disease, but normal CT scans of IV contrast should be adequate enough to detect lung lesions or lung cancer and lymphadenopathy.